So, today's lecture title is Acute cholecystitis. As far as you know, acute cholecystitis in general is the inflammation of gallbladder. Let's stop and have a bit recollecting information about biliary anatomy. As far as you know, there is a gallbladder that has fundus, body, and infundibulum. Then comes the cystic duct. This cystic duct connecting with common hepatic duct forms a common bile duct or haledichos. On this picture you can see how blood supply and lymph nodes located around the biliary tree. Biliary colic and cholecystitis are in the spectrum of biliary tract disease. And this spectrum ranges from asymptomatic gallstones to biliary colic, cholecystitis, choledicholithiasis, and cholangitis. Acute biliary infection comprises manifold disease concepts and is mostly separated into acute cholangitis, a systemic infectious disease that is occasionally life-threatening and requires immediate treatment, and acute cholecystitis, frequently presenting a mild clinical course. Acute cholecystitis develops in approximately 12 up to 20% of patients with biliary colic if they are left untreated. However, the incidence of acute cholecystitis is falling, likely due to increased acceptance by patients of laparoscopic cholecystectomy as treatment of symptomatic gallstones. On this scheme, you can see that cholelithiasis is divided into symptomatic and asymptomatic. Symptomatic cholelithiasis could be chronic or acute calculus cholecystitis. So symptomatic cholelithiasis can be a herald of an attack of acute cholecystitis or ongoing chronic cholecystitis, or it may resolve. So let's stop a bit more on the definition of the term. So, acute inflammatory disease of the gallbladder, often attributable to gallstones, but many factors such as ischemia, motility disorders, direct chemical injury, infections by microorganisms, collagen disease, and allergic reaction are also involved. If we're speaking about etiology of the disease, generally it's due to cystic duct obstruction, because gallstones are involved in more than 90 up to 95% of the causes. The main mechanism of the development of acute cholecystitis is bile stasis, activation of inflammatory mediators, and mucosal injuries. On this picture you can see the typical image, the typical situation how bile stones look like. In this situation, you can see on this picture bile stones in the hepatic ducts, which is uncommon but happens. About the incidence in patients with gallstones. No large epidemiological study has been conducted to date, but it can be estimated that approximately 10% of the general population have gallstones. Acute cholecystitis is the most frequent complication occurring in patients with cholelithiasis. The number of cases with acute cholecystitis has increased from 4 million to over 10 million through a decade. Gallstones account for 90 to 95% of causes of acute cholecystitis, as I've mentioned, and following cystic duct obstruction and cholestasis within the gallbladder due to the torsion of stones, gallbladder mucosa disorder occurs, thereby inducing the activation of infectious mediator. On the other hand, acute calculous cholecystitis accounts for up to 14% of acute cholecystitis. Risk factors include surgery, trauma, long-term intensive care unit stay, infections, thermal burns, and parenteral nutrition. Let's stop on the risk factors of acute cholecystitis. There is a rule which is called the rule of 4 Fs or 5 Fs, and they have been shown to be associated with lithogenesis in the gallbladder. However, it has not been established whether or not all these factors are associated with the development of acute cholangitis and cholecystitis. So, these Fs are age and female gender. There is no evidence to suggest the association of age and sex with the onset of acute cholangitis. But according to the Framingham study, which examined risk factors of cholelithiasis in subjects 30 up to 60 years of age followed for 10 years, the risk for development of cholelithiasis was largest in those subjects in the age ranging 50-55 years, and the incidence of onset in females was more than twice as large as in males at any age range and increased with age. The second factor is obesity. Patients with cholelithiasis are more likely to be obese than those without, and cholelithiasis is the major comorbidity of obesity. The proportion of cholelithiasis and cholecystitis in the obese aged 37 till 60 years is significantly higher than that in the non-obese. Then comes the role of pregnancy, fecundity, and fertility. No evidence exists to suggest an association between pregnancy and the onset of acute cholangitis and acute cholecystitis. The risk for cholecystectomy due to gallbladder disease in middle-aged female is increased with the frequency of delivery and decreased in proportion to the duration of lactation. Cholelithiasis accounted for more than 90% of the causes of cholelithiasis in pregnancy, was the most frequently encountered surgical disease next to appendicitis. Gallstones were detected by routine ultrasound imaging in 4% of pregnant women, although it is not known whether or not pregnancy is associated with the increased risk of cholangitis. Drugs as etiological agents. According to several reviews, drugs promoting the generation of gallbladder stones were indirectly associated with the risk of acute cholecystitis. There are also several other etiologies of acute cholangitis and cholecystitis. But you must remember this 4 Fs or 5 Fs rule. It doesn't tell you anything about the onset of acute cholecystitis, but that's definitely the risks, the factors of the risk of cholelithiasis. So, 40s, females, fat, fair, and fertile are associated with lithogenesis. It doesn't tell you much about the acute cholecystitis as the complication of lithogenesis, but that gives you the idea about cholelithiasis. So, other etiologies of acute cholangitis. There are two other etiologies of that process that would be Merizzi syndrome and Lamel syndrome. Merizzi syndrome is a morbid condition with stenosis of the common bile duct caused by mechanical pressure and or inflammatory changes caused by the stones present in the gallbladder, neck, and cystic ducts. Two types have been described. Type 1 is the morbid condition with the bile duct compressed from the left by the stones in the gallbladder, neck, and cystic ducts and pericholecystic inflammatory changes. And the second type 2 which is a morbid condition with biliary fistulation caused by pressure necrosis of the bile duct due to the cholecystolithiasis. Lemel syndrome is a series of morbid conditions in which the duodenal peripapillary diverticulum compresses or displaces the opening of the bile duct or pancreatic duct and obstructs the passage of bile in the bile duct or hepatic duct, thereby causing cholestasis, jaundice, gallstone, cholangitis, and pancreatitis. This picture shows you the typical situation that was described. Here you can see CT scan on the right side, that's C. You can see contrast X-ray on the left side. On this picture, you may see the described Lemel syndrome. Upper gastrointestinal endoscopy showing a diverticulum just above the papilla of Vater on the right arrow. And picture B describes you and demonstrates ERCP procedure with the findings of extrinsic compression in the lower biliary tract. That's the right arrow. The previous picture was showing you Mersey syndrome. MRCP showed the obstructed common hepatic duct but failed to visualize the gallbladder. On the picture B, cholangiography contrast X-ray study showed the stenosed common hepatic duct but failed to see and visualize gallbladder. And on the CT scan, that's the picture C, clearly shows that stones impacted in the gallbladder duct expanded the common hepatic duct, thereby inducing stenosis. As for the prognosis, the mortality rate in patients with acute biliary disorders have been reported to be up to 10%. According to reports after 2000, the mortality rate of acute cholecystitis was less than 1%, and no marked difference according to areas and communities is present. Now we move on to pathophysiology of the process. In the majority of patients, gallstones are the cause of acute cholecystitis. Gallstones can be divided into two categories: cholesterol stones that 80% of cases and pigment stones that 20% of cases. More patients with gallstones are asymptomatic, and stones may temporarily obstruct the cystic duct or pass through into the common bile duct, leading to symptomatic biliary colic, which develops in 1 to 4% of patients with gallstones annually. Cholecystitis occurs when obstruction of the cystic duct is prolonged, usually several hours, resulting in inflammation of the gallbladder wall. Cholecystolithiasis occurs when the stone becomes lodged in the common bile duct, with a potential sequela of cholangitis and ascending infections. Biliary sludge is a reversible suspension of precipitated particulate matter in bile in a viscous mucus liquid phase. The most common precipitates are cholesterol monohydrate crystals and various calcium-based crystals, granules, and salts. A portion of biliary sludge contains comparatively large particles, about 2 millimeters in size, called microlith, the formation of which is the intermediate step in the formation of gallstones in about 12% of cases. The process of acute cholecystitis is one of physical obstruction of the gallbladder at the neck or in the cystic duct by a gallstone. This obstruction results in increased pressure in the gallbladder, and there are two factors that determine the progression to acute cholecystitis: the degree of obstruction and the duration of obstruction. If the obstruction is partial and of short duration, the patient experiences biliary colic. If the obstruction is complete and of long duration, the patient develops acute cholecystitis. If the patient doesn't receive early treatment, the disease becomes more serious and complications can occur. Now we move on to pathological classification. The first one is edematous cholecystitis. That's the first stage, which lasts from 2 up to 4 days, typically. The gallbladder has an interstitial fluid with dilated capillaries and lymphatics. The gallbladder wall is edematous. Gallbladder tissue is intact histologically, and edema in the subserosal layer takes place. The second one is necrotizing cholecystitis, or the second stage, which lasts for 3 to 5 days. The gallbladder has edematous changes with areas of hemorrhage and necrosis, and when the gallbladder wall is subject to elevated internal pressure, the blood flow is obstructed with histological evidence of vascular thrombosis and occlusion. There are areas of scattered necrosis, but they are superficial and do not involve the full thickness of the gallbladder wall. On this picture, you may see necrotizing cholecystitis. On the picture A, contrast-enhanced CT images shows discontinuity of the gallbladder wall, suggesting possible presence of necrosis in a portion of the wall. On a B picture, resected specimen showing extensive falling off of the gallbladder membrane, erosion, ulcers, and exposed fascia. Histological necrosis of the gallbladder wall and separating inflammation accompanying abscess were absorbed with fibrillation and regenerating hyperplastic epithelium as background. The third type is suppurative cholecystitis. That's the third stage that comes on the 7th day. The gallbladder wall has white blood cells that present areas of necrosis and suppuration. In this stage, the active repairing process of inflammation is evident. The enlarged gallbladder begins to contract and the wall is thickened due to fibrous proliferation. Intramural abscesses are observed and do not involve the entire thickness of the wall. Pericholecystic abscesses are also present in this stage. Here you can see on the picture A, contrast CE visualizing the gallbladder wall under eccentric compression. That's the arrow you can see, which suggests possible presence of abscess in a portion of the gallbladder wall. Pictures B and C show many minute stones were observed within the gallbladder. And on the picture D, you can see the resected specimen with a gallbladder membrane accompanying extensive abscess formation within the wall. That's the arrowhead. Now we move on to chronic cholecystitis. That's the fourth stage if everything goes right. Chronic cholecystitis occurs after the repeated occurrence of mild cholecystitis attacks and is characterized by mucosal atrophy and fibrosis of the gallbladder wall. It can also be caused by the chronic irritation of large gallstones and may often induce acute cholecystitis. Acute on chronic cholecystitis refers to acute infection that has occurred in chronic cholecystitis. Histologically, neutrophil invasion is observed in the gallbladder wall with chronic cholecystitis accompanying lymphocyte plasma cell infiltration and fibrosis. On this picture, you see ultrasound images of acute and chronic cholecystitis patients. On picture A, the gallbladder wall is shown to have thickened prior to the onset of acute inflammation. On the picture B, the gallbladder itself continued to swell after the onset of acute inflammation, and the wall has further thickened along with the striated interluminal lucency. That's the upper arrow. Only by comparing the images before and after, that's A and B, the onset of acute inflammation can a decision of the wall thickening and the swelling of gallbladder can correctly be made. Now we move on to special forms of acute cholecystitis. That would be acalculous cholecystitis, acute cholecystitis without cholecystolithiasis, which happens in up to 15% of cases. There's also xanthogranulomatous cholecystitis. This cholecystitis is characterized by the thickening of the gallbladder with xanthogranulomatous cells and elevated intragallbladder pressure due to stones with the rupture of Rokitansky-Aschoff sinuses. This causes leakage and entry of bile into the gallbladder wall. It is ingested by histocytes to form granulomas consisting of foamy histocytes. Patients usually have symptoms of acute cholecystitis in the initial stage. Then we move on to emphysematous cholecystitis. In this type of cholecystitis, air appears in the gallbladder wall due to infection by gas-forming anaerobes, including Clostridium perfringens. It is often seen in diabetic patients and is likely to progress to sepsis and gangrenous cholecystitis. The fourth special form of acute cholecystitis is torsion of the gallbladder. Torsion of the gallbladder is known to occur by inherited, acquired, or other physical causes. The inherited factor is the floating gallbladder, which is very mobile because the gallbladder and cystic ducts are connected with the liver by a fused ligament. The acquired factors include splanchoptosis, senile humpback, scoliosis, and weight loss. Physical factors causing torsion of the gallbladder include sudden change of intraperitoneal pressure, sudden change of body position, pendulum-like movement in the antiflaxing position, hyperperistalsis of the organs near the gallbladder, defecation, and blow to the abdomen. Advanced forms and the type of complication of acute cholecystitis. So, the complications of gallstones in general are biliary colic, acute cholecystitis with empyema, gangrene, or perforation, obstructive jaundice, ascending cholangitis, pancreatitis, and gallstone ileus. As we move on to the types of complications of acute cholecystitis, we're gonna talk about perforation of the gallbladder, and it's caused by acute cholecystitis, injury, tumor, and occurs more frequently as a result of ischemia and necrosis of the gallbladder wall. The next complication of acute cholecystitis is biliary peritonitis. It occurs with the entry into the peritoneal cavity of bile leakage due to various causes, including cholecystitis-induced gallbladder perforation, trauma, and a detached catheter during biliary drainage, and incomplete suture after biliary operations. Pericholecystic abscess, a morbid condition in which perforation of the gallbladder wall is covered by the surrounding tissues, along with the formation of abscesses around the gallbladder. And the fourth one is biliary fistula, which can occur between the gallbladder and the duodenum following the episode of acute cholecystitis. This is usually caused by a large gallbladder stone eroding through the wall of the gallbladder into duodenum. If the stone is large in size, the patient can develop gallstone ileus with the stone causing mechanical small bowel obstruction at the ileocecal valve. Let's have a little stop at the pathological sequences during a bout of uncomplicated cholecystitis. So, as you can see, we have stones in the gallbladder. When the stone blocks the cystic duct, chemical and bacterial inflammation begin. But when the stone drops back into the gallbladder in several days, up to a week time or so, resolution follows through 2 months or so. But we can see that it may not happen, and when we have the blockage of the gallbladder with the stone, this inflammation would lead to inflammation of surrounding tissues, and resolution may follow with the dense adhesions, and that's the typical situation of the chronic cholecystitis. The next thing that may happen would be the formation of empyema or mucocele in the gallbladder. So, stone blocks the gallbladder. If infection comes there, you will have empyema. But if you don't have infection, just the blockage with no inflammation, sometimes that happens, you will have mucocele. On this picture, you can see that it happens when the block doesn't disappear. Or the worst situation we can have, that's the sequence of pathological processes that would lead to perforation of the gallbladder. And it doesn't mean that we must have stones. We may have stones in the gallbladder or may not. But when very severe inflammation with necrotic patches happens, that leads to perforation in 48 hours or even less, that happens mostly in older people. This perforation may lead to biliary peritonitis, and as on the previous picture, but if the perforation would be sealed off by surrounding tissues, you will have resolution with dense adhesions in the same 2 months. So, clinical presentation. The most typical clinical sign of acute cholecystitis is abdominal pain. Clinical symptoms of acute cholecystitis may include abdominal pain on the right upper abdominal pain, nausea, vomiting, and pyrexia. The most typical symptoms is right epigastric pain and tenderness in the right upper abdomen, a palpable gallbladder, and Murphy's sign are characteristic findings of acute cholecystitis. A positive Murphy's sign shows about 80 to 90% specificity for acute cholecystitis. The main symptom of uncomplicated cholelithiasis is biliary colic caused by the obstruction of the gallbladder neck by stones. The proportion of patients with right hypochondrial pain and epigastric pain combined is more than 70%. This is followed in frequency by nausea and vomiting, and note that the proportion of patients with fever is not so high. That of fever exceeding 38 centigrade is low, or about 1/4 of patients. Muscular defense is observed in about half of cases. Palpable tumors are rare in the right hypochondrial region. Rebound tenderness and stiffness are also rare. On this picture, you may see the incidence of clinical symptoms of acute cholecystitis in persons. Some words about the typical symptoms and clinical signs. So, the most typical for acute cholecystitis is of course Murphy's symptom, and it's a delay of breathing during palpation of gallbladder on inhalation. The next symptom is Kerr's symptom, which is strengthening of pain at pressure on the area of gallbladder especially on a deep inhalation. Ordinary symptom, that's painfulness at the easy pushing of right costal arc by the edge of palm. Missy's symptom, that's painfulness at palpation between the legs above a collarbone of the right nodding muscle. Blumber sign is the increasing of painfulness at the rapid taking away of fingers by which in front abdominal wall is pressed on. This symptom is not pathognomonic for cholecystitis, but matters very much in diagnostics of bile peritonitis. Complications symptoms. Hydropsy or mucosilla of gallbladder is its aseptic inflammation that arises up as a result of blockade of cystic duct by concrement of mucus. The bile from a bubble is sucked in and on replacement, transparent exudation accumulates in its formation. Urine palpation increase and unpainfully gallbladder is marked in all patients. Empyema of gallbladder is unliquidated in time hydropsy that at repeated infection is transformed in a new form. Gallbladder in such patients is palpated as a dense, moderately painful formation. However, the symptoms of irritation of peritoneum as a rule are absent. The high temperature of body is periodically observed, and in blood high leukocytosis with a shift of formula of blood to the left is present. Biliary pancreatitis. Worsening of the patient's condition, appearance of pain, frequent vomiting, signs of cardiovascular insufficiency, high amylosuria, presence of infiltrate in the epigastric area, and positive Voskresenski and Mayer-Robson symptoms are its basic signs. An icterus arises up at violation of passage of bile in duodenum as a result of obturation of choledicus by concrement, by putty or through the edema of head of pancreas. Thus icterus sclera, bilirubinemia, dark urine, and light unpainted excrement arise. Cholangitis. As for cholangitis, the Charcot triad is characteristic for the patient with this pathology. Next to pain syndrome and icterus, the temperature of body rises up to 39% centigrade. There is a fever, high leukocytosis, and decline of sizes of functional test of liver, which is observed. Diagnosis program would be first, anamnesis and physical methods of inspection, service scintigraphy of organs of abdominal cavity, sonography test, general analysis of blood and urine, diastase urine, biochemical blood test, and coagulogram. As for laboratory document, there are no specific blood tests for making a diagnosis of acute cholecystitis. So, the diagnosis can be made in the following findings are present. General inflammatory findings, that's abnormal white blood cell count, elevated CRP level, an increase in blood cell count more than 10,000 millimeters per deciliter, an increase of CRP level of more than 3, in a mild increase of serum enzymes in the hepatobiliary pancreatic system and the bilirubin. The bilirubin level may rise to 4 in the absence of complications. When ultrasonography shows findings that suggest acute cholecystitis and CRP level exceeding 3, a diagnosis of acute cholecystitis can be made with 97% sensitivity and about 76% of specificity. Some words about imaging considerations. Ultrasonography and nuclear medicine studies are the best imaging studies for the diagnosis of both cholecystitis and cholelithiasis. Ultrasonography is usually favored as the initial test, whereas hepatobiliary scintigraphy is usually reversed for 20% of patients in whom the diagnosis is unclear after ultrasonography has been performed. Plain radiography, computed tomography scans, and endoscopic retrograde cholangiopancreatography, that's ERCP, are the diagnostic adjuncts. Diffusion-weighted magnetic resonance imaging, or MRI, shows potential for differentiation between acute and chronic cholecystitis. So we move on to ultrasonography. And ultrasonography is the most common test used in the emergency departments for the diagnosis of biliary colic and acute cholecystitis. Ultrasonography is the test that should be performed first of all for every case of suspected acute cholecystitis. Even emergency physicians who are not specialists in ultrasonography generally are able to make a satisfactory diagnosis. This imaging modality may be diagnostic for biliary disease. It helps to exclude biliary disease or may reveal alternative causes of the patient's symptoms. Ultrasonography is about 95% sensitive for cholecystitis and has up to 80% specificity. For simple cholelithiasis, it's even more, up to 98%. The sonogram only shows gallstones within the gallbladder, but no evidence of cholecystitis on this sonogram. General ultrasonographic features. Findings include gallstones or sludge or one or more of following conditions. Gallbladder wall thickening, more than 2 millimeters, more than 4 millimeters. False positive wall thickening found in hypoalbuminemia, ascites, congestive heart failure, and carcinoma. Gallbladder distension with the diameter more than 4 centimeters and length more than 10 centimeters. Pericholocystic fluid from perforation or exudate. It may be seen as a hypoechoic or anechoic region seen along the anterior surface of the gallbladder within the hepatic parenchyma. Air in the gallbladder wall, indicating gangrenous cholecystitis. Ultrasonographic Murphy's sign, which is pretty sensitive but not too specific. It's the pain when the probe is pushed directly on the gallbladder with no relation to breathing. Some ultrasonographers recommend the diagnosis of cholecystitis in both ultrasonographic Murphy's sign and gallstones, without the evidence of any other pathology. As for the findings with or without cholelithiasis, additional findings in the presence or absence of gallstones may include dilated common bile duct or dilated intrahepatic ducts of the biliary tree, which indicate common bile duct stones. In the absence of stones, a solitary stone may be lodged in the common bile duct, a location that is difficult to visualize using ultrasound. There are also several advantages and disadvantages of ultrasonography. Advantages include imaging of other structures, for example, aorta, pancreas, liver, identification of complications, for example, perforation, empyema, or abscess, ability to be rapidly performed at the bedside, and in the emergency department, and absence of radiation. That's important in pregnancy. Disadvantages of ultrasonography include the fact this imaging modality is operator and patient dependent. It is unable to image the cystic duct and it has a decreased sensitivity for common bile duct stones. In addition, in the setting of concomitant acute pancreatitis, ultrasonographic findings alone are not adequate to accurately identify acute cholecystitis. Now we move to the second modality, which is biliary scintigraphy, and depending on the clinical setting, either ultrasonography or nuclear medicine testing is the test of choice for cholecystitis. The scans have pretty good sensitivity of 94% and a bit poor specificity about 75% for acute cholecystitis. Normal scans are characterized by normal visualization of gallbladder in 30 minutes. Oral cholecystography is not practical for the emergency department setting. These scans are functional studies of the gallbladder. Technetium labeled analogs of IDA or IDA-DIS-IDA are administered intravenously and secreted by hepatocytes into bile, enabling visualization of the liver and biliary tree. With cystic duct obstruction, cholecystitis, the HIDA scans show non-visualization, for example, considered positive, of the gallbladder at 60 minutes and uptake in the intestine as the bile is excreted directly into duodenum. This finding has a sensitivity of 80 up to 90% for acute cholecystitis. Obstruction of the common bile duct causes non-visualization of the small intestine. The RIM sign is a blush of increased pericholecystic radioactivity, tracer adjacent to the gallbladder, present in about 30% of patients with acute cholecystitis and in 60% with acute gangrenous cholecystitis. There are also several advantages and disadvantages of the scanning. For example, advantages of HIDA scanning include assessment of function and simultaneous assessment of the bile duct. In addition, although a gallbladder may appear normal by ultrasonography, the scan can depict an obstructed cystic duct abnormality. A high bilirubin can possibly decrease the sensitivity of this scanning, and recent eating or fasting for 24 hours may possibly affect findings. In addition, these scans do not image other structures in the area. False negative results filling in 30 minutes are found in less than 1% of studies, and filling between 30 and 60 minutes is associated with false negative rates of more than 15%. False positive results, that's about 20% of cases, occur when the gallbladder is not visualized despite a non-obstructed cystic duct. Causes include fasting patients receiving total parenteral nutrition, severe liver disease, which leads to abnormal uptake of the tracer, cystic duct obstruction induced by chronic inflammation, and biliary sphincterotomy, which decreases resistance to bile flow, leading to excretion of a tracer into the duodenum. The specificity of the test can be improved by intravenous administration of morphine, known as morphine cholecystography, which induces spasm of the sphincter, thus increasing back pressure to fill the gallbladder. Now we move on to abdominal radiography. The advantages of the abdominal radiographs include their readily availability and low cost. However, abdominal radiographs have low sensitivity and specificity in evaluating biliary system pathology, but they can be helpful in excluding other abdominal pathology such as renal colic, bowel obstruction, perforation. Between 10 and 30% of stones have a ring of calcium and therefore are radiopaque. A porcelain gallbladder may also be observed even on plain films. Emphysematous cholecystitis, cholangitis, cholecystic enteric fistula, or post-endoscopic manipulation may show air in the biliary tree. Air in the gallbladder wall indicates emphysematous cholecystitis due to gas-forming organisms such as Clostridial species and Escherichia coli. Here on this plain X-ray, you may see a pretty rare picture of the porcelain gallbladder filled with a calcium stone. We move on to computer tomography. and this scanning is not the test of choice and is recommended only for evaluation of abdominal pain if the diagnosis is uncertain. CT scans can demonstrate gallbladder wall edema, pericholecystic stranding in fluid, and high attenuation bile. A helical CT scan with fine cuts through the biliary tract has not been well studied but may be useful. Here on this CT scan picture you can see the typical picture of CT scanning. But there are also several advantages and disadvantages of this method. CT scan not only provides better information of the surrounding structures than ultrasonography, but it is also non-invasive. For complication of cholecystitis and cholangitis, gallbladder perforation, pericholecystic fluid, and intrahepatic ductal dilation, CT scans may be adequate. However, there are also several disadvantages as CT scanning misses about 20% of gallstones because they may be of the same radiographic density as bile. In addition, CT scanning is also more expensive. It takes longer because the patient usually has to drink oral contrast, and also given the radiation dose may not be ideal in the pregnant patient. We move on to ERCP procedure, that's endoscopic retrograde cholangiopancreatography. It provides both endoscopic and radiographic visualization of the biliary tract. This modality can be diagnostic and therapeutic by direct removal of common bile duct stones. There are several indications to this method. For example, ultrasonography, if it's 75% sensitive for cholelithiasis, scintigraphic scanning, computer tomography are not much better. Therefore, the dilated common bile duct is found or elevated liver function test results are present. Suspicion should remain high for common bile duct stones, and in this case, you must consider ERCP procedure. Debate exists as to when an ERCP should be performed. In general, because cholecystitis is caused by obstruction of the ducts, the risk of common bile duct stones is approximately 10%. Given its potential for complications, ERCP should be used when there is a high potential for intervention and should not be used solely as a diagnostic modality. Some studies have classified people as low risk for common bile duct stone based on first, that's lack of jaundice, second, elevated transaminase level, and three, a common bile duct diameter less than 8 millimeters. In this population, the risk of common bile duct stones may be as low as just 1%. In patients with any of the risk factors, the rate of stone is about 40%. Therefore, in general, people with any of the risk factors for common bile duct stones should undergo operative or ERCP evaluation of the common bile duct. Now we move on to major complications of this procedure, and that's pancreatitis and cholangitis. On this picture, you may see the typical ERCP picture with the stones in a common bile duct. So you see endoscope, which is pretty specific, and contrast in the biliary tree with no contrast where the stones are. So, diagnostic criteria for acute cholecystitis. A diagnosis of acute cholecystitis is made as follows according to diagnostic criteria. When acute cholecystitis is suspected from clinical signs and results of blood tests, a definite diagnosis is made after it has been confirmed by diagnostic imaging. Acute hepatitis, other acute abdominal diseases, and chronic cholecystitis should be excluded. Right upper quadrant pain, CRP, C-reactive protein, white blood cells. That's the second thing. A. Local signs of inflammation. That's Murphy's signs or tenderness or pain or right upper quadrant mass. And B. Systemic signs of inflammation. That could be fever, elevated CRP, elevated white blood cell count. And C would be imaging findings, characteristic of acute cholecystitis. So, you will have suspected diagnosis if you have one item in A and one item in B, but you will have definite diagnosis if you have additionally C, imaging findings characteristic of acute cholecystitis. So you always must confirm your examination, objective examination, and your lab test must be confirmed by digital imaging findings. Differential diagnosis. Diseases which should be differentiated from acute cholecystitis are gastric and duodenal ulcer, hepatitis, pancreatitis, gallbladder cancer, hepatic abscess, Fitzgerald syndrome, right lower lobar pneumonia, myocardial infarction, and urinary infection. You must also know about the severity assessment for acute cholecystitis. Patients with acute cholecystitis may present a spectrum of disease stages ranging from a mild, self-limited illness to a fulminant and potentially life-threatening disease. In fact, the overall mortality rate of acute cholecystitis is about 0.5%, and there were no severity assessment criteria for this common disease until 2007. Severity assessment criteria were first presented in 2007, where the severity grading of acute cholecystitis was classified into the following three categories: mild, that's grade 1, moderate, grade 2, and severe, grade 3. Severe acute cholecystitis was defined as acute cholecystitis associated with organ dysfunction. Moderate acute cholecystitis was defined as acute cholecystitis in which the degree of acute inflammation is likely to be associated with increased operative difficulty in performing cholecystectomy. And mild acute cholecystitis was defined as occurring in a patient who has no findings of organ dysfunction and mild disease in the gallbladder, enabling cholecystectomy as a safe and low-risk procedure. These patients do not have a severity index that meets the criteria for moderate and severe acute cholecystitis. The revised severity grading for acute cholecystitis is also present. On this picture, you can see the flow chart for the management of acute cholecystitis. But we'll stop a little bit on the criteria of severity of acute cholecystitis. Associated for the severe acute cholecystitis associates with the dysfunction of any of the following organs and systems: cardiovascular dysfunction with the hypertension requiring treatment with dopamine. The second would be neurological dysfunction with a decreased level of consciousness, respiratory dysfunction with a PA-FI ratio of less than 300, renal dysfunction with oliguria and creatinine level more than 2 milligrams per deciliter, hepatic dysfunction with PT more than 1.5, hematological dysfunction with a platelet count less than 100,000. As for the moderate acute cholecystitis, it's associated with one of the following conditions: elevated white blood cell count more than 18, palpable tender mass in the right upper abdominal quadrant, duration of complaints more than 72 hours, and the signs of the marked local inflammation for gangrenous cholecystitis, pericholecystic abscess, hepatic abscess, biliary peritonitis, and emphysematous cholecystitis. And criteria for grade 1 or mild acute cholecystitis is that it does not meet the criteria for second and third acute cholecystitis grades. It can also be defined as acute cholecystitis in a healthy patient with no organ dysfunction and mild or no inflammatory changes in the gallbladder, making cholecystectomy a safe and low-risk operative procedure in this case. So, the follow chart for the management of acute cholecystitis. The first line treatment of acute cholecystitis is early or urgent cholecystectomy, with laparoscopic cholecystectomy as the preferred method. In high-risk patients, gallbladder drainage, such as percutaneous transhepatic gallbladder drainage, percutaneous transhepatic gallbladder aspiration, and endoscopic nasobiliary gallbladder drainage is an alternative therapy in patients who cannot safely undergo early cholecystectomy. When a diagnosis of acute cholecystitis is determined based on the diagnostic criteria of acute cholecystitis, initial medical treatment including nil per os, intravenous fluids, antibiotics, and analgesia, together with close monitoring of blood pressure, pulse, and urinary output should be initiated. Simultaneously, severity assessment of acute cholecystitis should be conducted based on the severity assessment criteria, in which acute cholecystitis is classified into grade 1, grade 2, and grade 3. Assessment of operative risk for comorbidities and the patient's general status should also be evaluated in addition to severity grade. So, on this flow chart, you may see that if we have mild acute cholecystitis, antibiotics and general supportive care may lead to observation of the patient, or the better way would be early laparoscopic cholecystectomy. If we have grade 2 or moderate acute cholecystitis, we will also begin with antibiotics and general supportive care. But the operation would be performed. It may be emergency surgery if we have destructive acute cholecystitis. If the successful therapy happens, conservative therapy would be nice, then we will have delayed laparoscopic cholecystectomy or planned. If we have grade 3 severity, you have to add to antibiotics not just general supportive care, but general organ support, and perform urgent or early drainage and then delayed laparoscopic cholecystectomy. So, antimicrobial therapy for acute cholecystitis. Acute cholangitis and cholecystitis are common conditions that may result in progressively severe infection, particularly in debilitated hosts. The role of antimicrobial therapy in the broad range of diseases subsumed under the term acute cholecystitis also varies with severity and pathology. In early and non-severe cases, it was not obvious that bacteria play a significant role in the pathology encountered. In these patients, antimicrobial therapy is at the best prophylactic, preventing progression to infection. In other cases with clinical findings of a systemic inflammatory response, antimicrobial therapy is therapeutic and treatment may be required until the gallbladder is removed. Local antimicrobial susceptibility patterns and antibioticogram should be considered for use. Ampicillin sulbactam has little activity left against Escherichia coli, and it was removed from most of the guidelines. Fluoroquinolone use is recommended if susceptibility of cultures isolates is known or for patients with beta-lactam allergies. Many extended beta-lactamase producing gram-negative isolates are fluoroquinolone resistant. Anti-anaerobic therapy, including use of metronidazole, tinidazole, or clindamycin, is warranted if biliary enteric anastomosis is present. The carbapenems, piperacillin, tazobactam, ampicillin, sulbactam, cefmetozole, cefoxitin, flamaxef, and cefoperazone have sufficient anti-anaerobic activity for this situation. Vancomycin is recommended to cover enterococcus for grade 3 community-acquired acute cholangitis and cholecystitis and healthcare-associated acute biliary infections. Linezolid or daptomycin is recommended if vancomycin-resistant enterococcus is known to be colonizing the patient, if previous treatment. There are multiple factors to consider in selecting empiric antimicrobial agents. These include targeted organisms, local epidemiology, and susceptibility data, alignment of in vitro activity or spectrum of the agents with these local data, characteristics of the agents such as pharmacokinetics and pharmacodynamics and toxicities, renal and hepatic function, and any history of allergies and other adverse events with antimicrobial agents. Moxifloxacin have been investigated for intra-abdominal infections in several randomized trials. It was demonstrated that moxifloxacin is safe, well-tolerated, and non-inferior to the comparators such as ceftriaxone plus metronidazole. Tigercycline was under clinical trials for approval during preparation of the manuscript, and now it's approved for clinical use. Now we move on to surgical management of acute cholecystitis. Laparoscopic cholecystectomy is now accepted as a surgical procedure for acute cholecystitis when it's performed by an expert surgeon. Cholecystectomy has been used widely as a surgical procedure for acute cholecystitis. There have been several studies on the timing of cholecystectomy beginning in the era of open surgery and also in the current era of laparoscopic surgery. These studies have shown that early surgery conducted within 72 to 96 hours after the onset of symptoms is associated with advantages such as reduced hospital stay, sick leave, and healthcare expenditures, and no disadvantages with regard to mortality and morbidity. Recent randomized clinical trials and meta-analyses have indicated that laparoscopic cholecystectomy is preferable to open cholecystectomy, but surgeons should never hesitate to convert to open surgery to prevent injuries when they experience difficulties in performing laparoscopic cholecystectomy. Here you may see the typical equipment for laparoscopic cholecystectomy with radiological equipment when we suspect cholelithiasis in common bile duct, for example. You may see laparoscopic unit, anesthetic unit, instrumental table, electrocautery, and of course operating table. That's typically how the equipment of the operational room looks like. The optimal treatment for acute cholecystitis is essentially early cholecystectomy and the use of an established optimal surgical treatment for each grade of severity of acute cholecystitis is necessary. It is preferable to perform cholecystectomy soon after admission, particularly when less than 72 hours have passed since the onset of symptoms. As far as I mentioned before, early laparoscopic cholecystectomy is indicated for patients with grade 1 acute cholecystitis because laparoscopic cholecystectomy can be performed in most of these patients. Early laparoscopic or open cholecystectomy 72 hours after the onset of acute cholecystitis is required in patients with grade 2 moderate acute cholecystitis in experienced centers. But for some patients with grade 2 acute cholecystitis, it is difficult to remove the gallbladder surgically because of severe inflammation limited to the gallbladder. This severe local inflammation of the gallbladder is defined by factors such as 72 hours and more from the onset, white blood cell count more than 18, and palpable tender mass in right upper abdominal quadrant. Continued medical treatment or drainage of contents of the swollen gallbladder by percutaneous transhepatic gallbladder drainage or surgical cholecystostomy is preferable, and a delayed cholecystectomy after the improvement of inflammation of the gallbladder is indicated. Among patients with grade 2 moderate, for those with serious local complications, including biliary peritonitis, pericholecystic abscess, liver abscess, or for those with gallbladder torsion, emphysematous cholecystitis, gangrenous cholecystitis, and purulent cholecystitis, emergency surgery is conducted, open or laparoscopic depending on the experience of the surgeon. Along with that, the general supportive care of the patient should be done. The urgent management of grade 3 or severe acute cholecystitis is always necessary because the patients have organ dysfunction and the simultaneous drainage of the gallbladder contents is required to treat the severe inflammation of the gallbladder. The delayed cholecystectomy is required 2 to 3 months later after the improvement of patient's general condition when cholecystectomy is indicated. Here's the typical idea of cholecystectomy scheme. That's the creation of critical view of safety. Callous triangle is dissected free of fat and fibrous tissue, and the lower end of the gallbladder is dissected off the liver bed. It is not necessary to expose the common bile duct. The critical view of safety is now the ultimate standard to prevent bile duct injuries during laparoscopic cholecystectomies. Failure to create this view is the indication for conversion to open cholecystectomy. So, the first step in laparoscopic, for example, cholecystectomy, is exposing the cystic duct and artery. That's forming the critical view with the traction of Hartmann pouch, with the traction of the fundus of gallbladder to expose the cystic duct and artery and to see this specific callous triangle. The second step would be dissecting the cystic duct and artery. So graspers are used to retract the gallbladder and to expose cystic duct and to dissect it. The third step is not always made. When you suspect common bile duct stones, you perform intraoperative cholangiogram. That happens in most cases before the cystic duct is clipped. When the dissection was made, the step 4 would be transecting the cystic duct and artery with placing clips on the cystic artery, at least 2, on the cystic duct, at least 2 from the proximal stump. Then comes the dissection under tension. And the last thing, the step 5, is dissecting the body of the gallbladder using traction of the gallbladder and, in most cases, electrocautery hook. When there is suspicion for common bile duct stones, the intraoperative cholecystoscopy is performed, or cholecystography, with the traction of the gallbladder to have nice open common bile duct. That's how the typical intraoperative cholangiogram looks like. You may see the tube inserted in the common bile duct and a contrast in bile ducts. You may also see 2 stones in the common bile duct. Alright, but there are also complications of golden standard laparoscopic cholecystectomy, and they were reported soon after its introduction, and they include bile duct injury, intraperitoneal hemorrhage needing laparotomy, bowel injury, hepatic injury, as well as the commonly observed complications associated with conventional open cholecystectomies, such as wound infections, ileus, atelectasis, deep vein thrombosis, and urinary tract infections. Bile duct injury is considered to be a serious complication. In spite of many improvements in the technique and equipment, as well as the surgeon's learning curve, the bile duct injuries rate remains high compared to open cholecystectomy. Bowel and hepatic injuries should also be carefully avoided as serious complications. These injuries have been attributable to the limitations of laparoscopic procedures, such as narrow view and non-tactile manipulation. Laparoscopic cholecystectomy is not always associated with the higher incidence rate compared with open cholecystectomy, but any serious complication that requires reoperation and/or prolonged hospitalization may become a serious problem for patients, even those who firmly believe that laparoscopic cholecystectomy is less invasive. So, the optimal treatment according to the grade of severity is as follows. Grade 1, early laparoscopic cholecystectomy is the preferred procedure. Grade 2, acute cholecystitis, early cholecystectomy is recommended in experienced centers. And grade 3, severe acute cholecystitis, urgent management of organ dysfunction and management of local inflammation by gallbladder drainage should be carried out, and elective cholecystectomy should be performed when cholecystectomy is indicated. Thanks for your attention.